everyone. Welcome to a brand new episode of our academic program on obesity management hosted by DocPlexus and the Center for Metabolic Surgery. So headed by Dr. Raman Goyal, Center for Metabolic Surgery is among India's top bariatric surgery centers with a comprehensive team of surgeons, physicians, dietitians, psychologists to assist on weight loss surgeries. So every Thursday, same time, we host clinical discussions around obesity management. And this program will include an expert opinion of our guest speaker, along with the patient testimonial and experience sharing about the treatment. So today we will be discussing about obesity and heart diseases. So I would like to welcome Dr. Ravi Gupta, our guest for today. A very good evening, sir.
Hi, good evening. How are you?
Very well, sir. So talking about our speaker today, Dr. Ravi Gupta is a renowned cardiologist in Mumbai and currently practices in Wokhart Hospital in Mumbai Central. For past 22 years, Dr. Ravi Gupta has worked as a cardiology doctor and gained proficient skills and knowledge in the segments. So, and Dr. Ravi Gupta has also pursued his degree of MBBS from SMS Medical College in Jaipur and MD from Medicine from RNT Medical College in Udaipur. He has been rewarded with various awards, including he had been selected for a Best Young Interventional Cardiologist in India and Rajasthan Gaurav Award as well. Some of the treatments offered by Dr. Ravi Gupta are pacemaker surgery, peripheral angioplasty, peripheral angiography, coronary angiography, and coronary angioplasty. So I would like to welcome you, sir, on DocPlexus.
Thank you very much, Darshika, for your kind introduction. And I am thankful to the DocPlexus and Dr. Raman Goyal, sir, that I was being involved in a topic of my interest. I mean, this is one topic which I always speak from my heart. So, I mean, we have been seeing so many patients and we know that how obesity and heart disease go hand in hand. So, this is, I'm quickly go through these initial slides. We all know that obesity is something which is excess of adipose tissue. So, it may not be a meaningful distinction between the lean and obese people as we talk about the medical distinction, but as far as obesity is defined as assessing its linkage to the morbidity and mortality. So we are more concerned about the things which are making these obese people sick and they are more chances to lose their lives. Genetics has a major role in obesity that we all know. Body weight is also influenced by so many things like genetics, metabolic disorders, like behavioral abnormalities, environmental factors, of course, diet, cultural, and socioeconomic influences. So we have therefore behavioral and environmental factors. They are going to provide us the greatest opportunity for actions and intervention. I mean, these are the two things which we can work upon. These are the very basic measures to assess adiposity, body mass index, anthropometry, and CT, MRI scan, and electrical impedance. So I'm not going in detail of this. Dr. Goyal will speak on this and he will educate us about the bariatric surgeries, how we can achieve good results in obese people. By definition, on a simple term, I would say that waist circumference is a very, very common and readily available measure to decide whether this patient is obese or not. So for a rule of thumb, you can say anybody who has a waist circumference more than 40 inches in a man and 35 inches in a woman, it indicates high waist circumference and it falls into the category of obesity. Similarly, we can decide on the basis of BMI. The normal BMI is 18.5 to 24.9. This is the normal BMI. And if somebody is having BMI more than 29.9 or you can say 30, then obesity starts. And by definition, we can divide obesity further, classify into three categories, class 1, 2, and 3. And who falls into more than 40 BMI, they are obesity class 3 people. These are the classical risk factors for CAD. So we all know that diabetes is one disease which is very common in our country, and sorry, we are known as diabetic capital of the world. And let me tell you that diabetes is one disease which increases the chances of CAD by 3 to 4 folds. And unfortunately, these diabetic patients, they lose their senses of pain also. So a large number of diabetic patients, they don't have typical chest pain, which is a clear-cut sign of coronary artery disease. So we need to have a high degree of suspicion in diabetic patients. Smoking is definitely a risk factor for CAD, especially young people, because smoking causes a thrombus formation and a clot can sit in the coronary arteries and it can lead to myocardial infarction. Hypertension, dyslipidemia. I would say that dyslipidemia is something like dyslipidemia and obesity, they go hand in hand. So we need to understand that almost everybody who is obese, they have some or the other abnormal lipid parameters in their lipid profile. And these are the obesity and overweight increases the risk of these things. I mean, if somebody is obese, then he is more prone to have hypertension, he is more prone to develop stroke, he is more prone to develop diabetes, he is more prone to develop metabolic syndrome, cardiovascular mortality. Some cancers are also known to occur more commonly in obese people. Gallbladder diseases, osteoarthritis is also commoner in obese people, and definitely sleep apnea syndrome, that is also very common in obese people. So when we talk about the direct relation of BMI with the relative risk of these things, so in this slide you can easily make out, as the BMI keep on increasing, these all things, like if you see diabetes, the diabetes keep on increasing. The relative risk of diabetes increases, similar to the risk of hypertension, cholelithiasis, and coronary heart disease. These all keep on increasing as the BMI increases. Similarly, if you see the chances of myocardial infarction, these are also higher when we talk about the BMI increasing. This is how the obesity causes the cardiovascular disease. It's actually very simple to understand. I mean, if you think about the basic metabolism, then you would easily understand that how obesity is going to affect the metabolism and how it is going to increase cardiovascular disease, like age, gender, and gender mechanisms. And this is how you see these two pictures. These two pictures are very, very classical pictures of adiposity, or you can say the body fat distribution. In the visceral type adiposity, this is actually the abdominal obesity. And this is also known as apple-shaped or the android obesity. This usually seen in men. And the another type of obesity, which is known as external type or the lower body obesity, which is more commonly known as pear-shaped or gynoid obesity. This type of obesity is actually bad. So when obesity is going to affect the abdomen, I mean, when we are talking about the abdominal obesity, which is actually the deep visceral fat, and this is going to cause that the lipolysis, which normally happens because of the insulin, that lipolysis become insensitive to insulin. So even if the insulin is there, it is not able to break the lipid. So the lipid is actually, lipolysis is actually keep on increasing, and it leads to free fatty acids. And then this free fatty acid is going to affect three major organs in our. If we talk about the muscle and pancreas, you can see that the insulin resistance is going to occur, metabolic syndrome will occur, and type 2 diabetes will occur. Similarly, when we are talking about the effect of free fatty acids on liver, then you can see the gluconeogenesis, it means the new generation of glucose. Similarly, increase triglycerides, increase LDL, and decrease HDL. HDL is a good cholesterol and LDL is a bad cholesterol. So we have a direct correlation of LDL with increased CAD, and decreased HDL is also associated with increased CAD. Similarly, when we talk about the blood vessels, you can see a stiffening of the arteries, which causes hypertension, hypercoagulable states, and the endothelial dysfunction. Endothelium is the layer of the, this is the innermost layer of all the arteries, and all blockages actually start with the endothelial dysfunction. So the innermost layer, which is known as endothelium, when it becomes ill, that time it has more chances to progress in an abnormal way, which can lead to blockages. When we talk about the insulin resistance, then we need to understand the concept of hyperinsulinemia and hyperglycemia. These are the two things which are going hand in hand, and because of these things, you can see that the sympathetic nervous system gets activated, which leads to the increase in the arterial tone, what I was talking, the stiffening of the arteries, and this leads to higher blood pressure. Primarily, it causes higher systolic blood pressure. And similarly, these patients have sodium reabsorption. So sodium takes water along with this, and it also leads to increase in the cardiac output or the circulating blood volume, and it also leads to hypertension. The pancreatic beta cells are overstimulated, so the reduction of insulin secretion happens, and this leads to type 2 diabetes. And this is one condition when insulin is there, but insulin is not acting properly. And this is because because of the adipose tissue, the insulin which is being secreted from the pancreas, it is not reaching up to the target cells. So the response which is normally generated by a X quantity of insulin, that is not there. And this is actually the common cause of type 2 diabetes, in which patients have normal functioning pancreas, normal release of insulin, that insulin is also healthy, working, but it is not able to reach up to the target tissue because of the adiposity. And at times when we are able to get rid of this obesity by whatever means, I mean, either you exercise, or you do dieting, or you underwent some bariatric surgery, ultimately when you cut down this fat, this insulin start working onto the target tissue. And these are the things which happens with insulin resistance, as I was talking about the endothelial dysfunction. Similarly, the systemic inflammation happens, which leads to atherosclerosis. Atherosclerosis, I would say something like developing blockages. And atherosclerosis, believe me, it's a generalized process. I mean, somebody can have blockages in the heart arteries, which would lead to coronary artery disease. Somebody develops blockage in the carotid arteries or the brain arteries, which can lead to stroke. If somebody has blockage in the renal arteries, it can lead to uncontrolled hypertension. And similarly, if somebody has blockages in the limb arteries, they can have peripheral vascular disease. Visceral obesity is another manifestation of this, type 2 diabetes, as we discussed, hypertension, and abnormal lipids. So, which I told you that primarily LDL, which is considered a bad cholesterol, it keeps on increasing, and it has a direct correlation with coronary artery disease, and for that matter, atherosclerosis. I mean, not only coronary artery disease, these patients are more prone to develop blockages in all other parts of their arteries. This is the syndrome which has been described, and these are the clinical manifestations of insulin resistance syndrome. These patients have central adiposity or obesity. They have glucose intolerance. Because of the fact, they are more chances to develop atherosclerosis. They are stiff arteries, so they have more chances to develop hypertension, and they have polycystic ovary disease also. And these are the biochemical markers which we have discussed earlier. And how this insulin resistance is actually connected with heart disease. As I told you that these all things are more common in those who have insulin resistance, and unfortunately these all conditions are directly related with heart disease. So if you talk about the diabetes, if you talk about hypertension, low HDL, which is a good cholesterol, high triglyceride, I would say, may or may not be directly related with the heart disease, because initially people used to think that triglyceride is directly related with heart disease, but not even a single large randomized trial is available which correlates high triglyceride directly with CAD. So there are multiple small trials. Triglyceride, I would say, primarily affecting the pancreas. So pancreatitis can happen in these patients, and diabetic patients in any case have abnormal triglycerides. So CAD, I have my concept that triglycerides per se are not directly related with CAD. And we talk about the LDL. I mean, whenever we have a small dense LDL, whatever the small size, the smaller size of LDL is more atherogenic. So some people, they actually do further lipid profile assessment in which they find that even the smaller LDL particles, the counts may be the same. But if somebody has larger number of smaller LDL, they are more atherogenic. Endothelial dysfunction, there are several ways to decide endothelial dysfunction by non-invasive methods also. I remember when I was in Escorts too, we did a study in which we did the carotid intermedial thickness. So intima-medial thickness was a non-invasive tool in which we used to measure the thickness of carotid, artery, intima and media. And based on their ratio, we used to assess their probability of developing CAD, and more or less we were right. So we published the data also that time. Left ventricular hypertrophy is also an indicator of prolonged hypertension, and this is also directly related with the heart diseases. So these are the risk factors of metabolic syndrome. This all we have discussed earlier. I would say HDL is a good cholesterol. So anybody in a man who has less than 40 milligram per deciliter HDL, they are more prone to develop CAD, and women less than 50 HDL is considered bad. Fasting glucose is defined. I mean, somebody would say that more than 110 sugar is abnormal. I would go one step higher. Less than 100 is normal. 100 to 109 is pre-diabetes, and more 110 or more is diabetes. So this is the metabolic syndrome association with cardiovascular mortality. Clear-cut difference you can make out. Who has no metabolic syndrome, the chances of CV mortality is 2.2. And who has metabolic syndrome, the chances of CV mortality is almost 6 times higher. So these are the things which we can manage: type 2 diabetes and cardiovascular events. How do we manage these metabolic syndrome patients? So, of course, weight loss becomes the key. Proper diet and exercise, which is also integral part of the treatment. There are some drugs which make a person more sensitive to the insulin. So these patients can work with the similar level of insulin nicely. Similarly, statins, if we are able to control LDL, statins are wonderful drugs. And I would say, I mean, so many people, they stress on diet. I would say diet is important because that is a modifiable thing. But if we talk about overall lipidology, then I would say that 80 to 85% of our cholesterol is being affected by our genetics. So you can't do much with only diet. I mean, somebody starts starving, then it doesn't mean that he can control his LDL. We have wonderful drugs like statins, which melt cholesterol like anything. Niacin, again, I have some reservations about niacin because niacin is a lot of flushing. Some people, they introduce niacin slow release and they claim that the flushing is less or no flushing at all, but this is practically not possible with a drug like niacin. So it is not going to help much in increasing the HDL, omega-3 fatty acids, and fibrates for triglyceride. This is another common scenario which we all see: obesity hypertension. These patients have direct relation of obesity with hypertension. I mean, if you see, these patients are known as hypertensive and obese. When they start decreasing their weight, body weight, believe me, their blood pressure also starts settling down. And the direct correlation of obesity and hypertension is so tight, then you can make out that 70% of hypertension in men and 60% of the hypertension in women are associated with extra adiposity, and the reverse and vice versa is also true. I mean, if you are able to control your extra pounds, you are able to control your blood pressure also. When we talk about the relation of hypertension with BMI, again, this is a very clear-cut slide which is showing the chances of hypertension will keep on increasing as your BMI keeps on increasing, and it holds true for both men and women. Obesity and hypertension, this we have discussed, so I'm not going on this. When we talk about the mechanism by which the obesity may cause hypertension and renal injury, by activation of the renin-angiotensin system and the sympathetic nervous system, metabolic abnormalities and compression of the kidneys. This is also a complex slide, but I would say to make it simple, you need to remember only 2-3 things. That one is the renin-angiotensin system, which we know that it is bad. It is going to cause endothelial dysfunction and so many things in our not only coronaries but every vasculature of our body. Sympathetic nervous system is going to increase our heart rate and blood pressure, and it is going to cause the stiffening of the arteries. And when we talk about their effect on the kidneys, the renal vasodilation occurs and glomerular hypertension occurs. Similarly, when the sodium is reabsorbed, it takes the water along with this. So the volume will be expanded. These patients will again have high blood pressure. Cholesterol has direct effect. Glucose intolerance is again increasing the carbohydrates, glucose in our body, and ultimately this is all going to cause glomerulosclerosis. It means the renal artery, the renal system is getting disease. So this is how the hypertension happens in these patients. This is what we have been talking, the sodium excretion is reduced. So sodium retained in the body, it causes stimulation of the sympathetic nervous system. Sodium and calcium content of the vascular smooth muscle cells increases the tone of the vascular smooth muscles, and this causes total circulating volume, high sodium content further increase with the flow. The sympathetic drive will increase the blood pressure, increase the heart rate, and these vascular smooth muscles start proliferating, and it causes proliferation of the AT1 receptors. This is the crux of my talk, and probably you can correlate everything in this slide. When we talk about the visceral obesity, as I was talking, the sodium will be retained in the body, which will lead volume expansion, which will going to increase the cardiac output. It increases the sympathetic drive, so it increases the heart rate and blood pressure. Again, it is going to increase the cardiac output. The visceral obesity will cause activation of the renin-angiotensin system, which is going to lead to endothelial dysfunction, diabetes mellitus, dyslipidemia. This is leading to atherosclerosis. And overall, this increased cardiac output and stiffening of the arteries is going to lead to hypertension. Then ultimately, these are the common features which happen in a patient of all these features. They either have coronary artery disease, or they come with a congestive heart failure, or unfortunately, few of the patients, they have some abnormal rhythm which can lead to sudden cardiac death. So these are the issues in choice of antihypertensive therapy in obese patient. This is also important. I mean, when we are choosing an antihypertensive drug, so what we should keep in our mind? One thing, we should target a drug which reduces the preload and afterload, both. There should not be any neuroendocrine activation, because this is ultimately going to increase your sympathetic drive. Metabolic effect should be favorable. These drugs should not be cause weight gain. Reduction in renal hyperinflation and microalbuminemia, that is also important. These drugs should be effective for 24 hours a day. That is also very important, because this is going to make a patient compliant with the drug therapy. And most of the time, when we choose a drug for hypertension, we try to choose a drug which is effective for 24 hours. I mean, once a day drug therapy, because these drugs are actually to be taken to their lifetime. And unfortunately, hypertension per se have no symptoms. So most of the people, those who are hypertension for long but no symptoms, for them it would be difficult to make them convinced that this medicine has to be taken on regular basis. So if you are telling that if you are able to take once in a day, that is still acceptable. But if a patient is supposed to take multiple doses of a drug, then may be difficult. So this is just a rough thing. Of course, I can go on and on about the hypertensive medication, but I would say that if you talk about these are the 3-4 options available with you. I would say that ARB would be the best choice. Even ACE inhibitors are not good choice as far as control of hypertension is concerned. They will give you benefit of endothelial dysfunction. They will control the renin-angiotensin system. But if you talk about the control on blood pressure, ARB is a better choice than ACE inhibitors. Low-dose diuretics are also almost always given in these patients, those who are fluid overloaded, and they respond very nicely with a low-dose diuretic. But we should make sure that this diuretic drug should be in low dose only. If you are giving in high dose, then it starts causing electrolyte imbalance and patient can come with some other issues. Calcium channel blockers are helpful in decreasing the arterial tone. So these are very effective when we are dealing with the systolic hypertension. Beta blocker, I would say, only and only use when you are dealing with a patient of obesity and coronary artery disease. Otherwise, I won't recommend beta blocker per se in a patient of obesity, because beta blocker themselves, they increase obesity. They are known to increase peripheral vascular disease and some lung issues also, and of course sexual dysfunction. So beta blocker would not be on my top list when I'm choosing a hypertensive drug. These are the direct benefit, and these all are demonstrated benefits. Modest weight loss defined as a minimum of 5 pounds weight. I mean, just almost 2.5 kg weight, and you see the effect. The risk of death decreases possibly. The risk of MI, the risk of stroke, and the lipid profile improves. When we talk about the prognosis in type 2 diabetes, the insulin requirement decreases and sugar control is better. If somebody is having sleep apnea, is definitely going to get relief in his breathing pattern when he loses his weight. When the patient loses his weights, the joints also are able to bear their weight nicely. So the chances of osteoarthritis and at least their symptoms of osteoarthritis, they decrease. And of course, the relapse rate of asthma can also decrease. So these are the basic things when we talk about. I'm not of this because I think Dr. Goel will teach us better about this. These are the 2-3 last slides which I'm going to speak on. These are very, very practical issues which we see on day-to-day basis. How to evaluate for CAD in obese patients. Because what happens, most of these obese people, they have their limited activities. And for CAD, these patients have limited activity, so they won't feel any angina, they won't feel any breathlessness because their activity is limited. And CAD is one disease which will be manifest easily when the patient develops chest heaviness on exertion or he develops breathing difficulty on exertion. So by history, if I ask someone, do you have any chest pain on walking or do you have any breathing difficulty on walking? He may has obesity, and along with this has multiple risk factors for CAD. Like a patient who is obese, he has diabetic also, he has hypertension also, he has hypothyroidism also. These patients have more chances of developing CAD. So you need to have a clinical suspicion. Another thing which is very important, at times we just rest assured by a normal ECG and a normal 2D echo. Please try to understand, I mean, normal ECG and normal echo does not ensure that there are no blockages. It can very easily happen. At least 40% of our patients of severe triple vessel disease, they may have absolutely normal echo. So it doesn't mean that there is no CAD. These patients are required to do any functional test, and normal or very easily accessible.
Dr. Darshika,
Clear-cut refuse, and even if they are able to do it, they are not able to complete. Sorry, some comment or something in between?
Sorry, sir, I think your video got stuck, so no problem. So you can go ahead, no problem.
Yeah, am I audible clearly?
Yes, yes, very much.
Okay,
Thank you.
okay. Now I'm coming to another way of evaluating CAD in these patients. So you can't do stress test also. You cannot fully rely on ECG and 2-day echo. Patient doesn't have any symptom. Other test which comes is Dopamine stress echo. But again, these obese people, they don't have good transthoracic window. So for DSC, you need to have very good window. So you increase the heart rate by giving the dopamine drug, and you keep on imaging and then look for any new regional wall motion abnormality. That is also not very feasible in obese patients. So we are left with either stress thallium test, or we can go for a CT coronary angio, or if you have a high degree of suspicion, I would say that conventional angio would remain the gold standard. Of course, a patient who is asymptomatic, who has no classical risk factors, we will not go for a straight angiogram. But if you have a strong clinical suspicion, and especially a patient going for some surgery, which happens when these obese patients are referred to us for either some bariatric surgery or some non-bariatric surgery, when they are referred to us for some cardiac clearance. In those patients, to be very, very sure that nothing haphazard is going to happen in the operation theater, we try to make sure that there is no CAD or no significant CAD. These are again very practical challenges in intervention. What happens in those obese patients? Conventionally, we do angiography from the groin, and they have very thick thighs, and the groin is also not in alignment with the inguinal ligament. So at times our punctures are going to lead in local complications like hematoma or pseudoaneurysms or AV malformations. So these are always higher chances of groin complications in obese people. So I would always try to find a good radial artery. If radial artery is not there, then I would find an ulnar artery and try to do all my procedures in obese patients from wrist. If by any means, like you are dealing with a post-CABG patients, or you are doing to perform some complex left main disease procedure or some bifurcation case, in those cases, if you are forced to use a groin, then I would prefer to use image-guided puncture. So image-guided, either we do under the fluoroscopic guidance, where we make sure that our puncture is exactly at the femoral head, or we take the ultrasound probe in our left hand and we see the artery in front of our eyes, and then we puncture to make sure that we are not puncturing here and there. And other ways of doing is micropunctures. Micropunctures are also very, very nice things which can help us from so many complications. Normally, we take a routine puncture needle to puncture the groin. These micropunctures are very, very thin bore micropuncture needles in which we can enter inside the femoral artery, and once we are sure that we are in the artery, we give a small amount of dye and we take a shoot. So we make sure that our puncture is right. At the same time, we decide that our puncture is at the same right level. Our puncture should be above the bifurcation of the superficial femoral artery and the profunda artery. So it should be in the common iliac artery. So this is how we able to define. And once you are sure with your micropuncture, if you are not sure, that you can always change the micropuncture. This is the advantage of micropuncture, that you are nothing to lose. I mean, if you are not happy with this micropuncture, you can take out that puncture needle very smoothly. This is not going to cause any trauma to the artery. You can select another micropuncture. Once you are sure, then you can convert it to the routine puncture needle, then you take your sheath, complete your procedure. And after finishing the procedure, we have devices which are known as closer devices. These devices, we fix the sheath inside the cath lab only. So we take out that sheath in the cath lab, we put a knot inside the artery puncture site, and there's no need of keeping the sheath, no need to keep the leg straight for another 6 hours, and of course no chances of any local hematoma. So these are the practical issues which we deal. And this is one cartoon from my book that whenever we talk about obesity, you have to be fit. You have to fit like Dr. Raman Goyal sir. Then only you can convince your people to go for bariatric surgery. This is a dear friend, Dr. Vishal Hathi. He's a weight watcher, obesity expert. So preaching is easy, but you have to be a role model. And thanks for your patient listening. And if you have any queries, any suggestions, most welcome. Thank you very much for your patient listening.
Thank you so much, sir. And before we go to listen to Dr. Raman Goyal's expertise on the subject, I think, could we take the question answers first?
Yeah.
Yeah, sure.
Yeah. Okay. So thank you so much, sir, for such an engaging talk. Could we stop the screen share here?
Yeah.
So my first question is from Dr. Anand Prakash Rao, who would want to know how long one should take statin after CABG, keeping the age in mind.
Good question. Good question. So one thing we need to understand that LDL values which are defined in the lab reports should not be relied upon, because these reports people are not even aware of. I mean, whenever we discuss about LDL values, I would try to make it very, very simple. LDL, we can categorize patients in 3 categories. The highest risk category group is those who are already CAD or diabetic patients. So the patient who underwent a bypass surgery or underwent an angioplasty or under medical treatment, but they have CAD, or diabetes is considered CAD equivalent. In those patients, the LDL goal is less than 70. Wow. Nowadays, we have multiple data which suggests that LDL should be kept below 50. So most of the time, those patients are post-CABG patients. They should keep on taking statin on a maybe a maintenance dose that depend on their lipid profile report. So of course, no idea of stopping statin after statin. Another group which we are talking is moderate risk. These patients are having no CAD, they have no diabetes, but they have one or more risk factor for CAD. Like these patients has obesity, these patients are current smokers, or these patients are hypertensive, they have positive family history. In these patients, the target of LDL is less than 100. And the third group comes in which there is no risk factor, no CAD, like a healthy man. So in those people, I would say the LDL should be kept less than 130. So this all things are not actually written in the reports. So some people actually, they assess their lipid profile on their own, becomes slightly difficult.
Thank you so much, sir. I hope, Dr. Anand, that answers your question. My next question is, so because you did talk about the health benefits of modest weight loss, what is metabolically healthy obesity? And could you help us understand the pathophysiology behind it?
Metabolically healthy obesity.
Yes.
This is a new term. I mean, Goyal sir, can you? I mean, I'm sorry, but probably I'm not working much on obesity. So for me, this term is new. Sir, can you please guide us? This term is something.
So, Dr. Ravi, there are multiple publications to say now that there is nothing like metabolically healthy obesity. So even though the triglycerides and LDL and insulin resistance is not there, but still it leads to endothelial dysfunction and other things. So, Dr. Darshika, disappointing to many of your observers, but scientifically there is nothing like that. Yeah.
No problem, sir. So I think that brings me to my last question. So, Dr. Gupta, what is your observation on epicardial fat deposits and CVD risk?
Epicardial fat has no correlation with CAD.
So, sir, because epicardial fat deposits have shown reductions after CPAP therapy, so should this be used only on patients with sleep apnea or could also be used on other patients as well?
I am not expert on sleep apnea, so I won't be able to say that whether the reduction of epicardial fat happens when we are decreasing the epicardial fat. But for us, actually, epicardial fat is a routine finding which we see around the heart during a routine echoes. So, and believe me, I don't think that there is any direct correlation of epicardial fat with coronary artery disease.
No problem, sir. So we received one more question from Dr. Achyut Gogoi, and he says, what diet plan should we follow to maintain a healthy heart? If you want to comment on that.
Yeah, I'm a liberal cardiologist, so I always make my patients happy, and their wives don't like my advices. So, because what happens after angioplasty or bypass surgery, their wives becomes the instructors. So they actually come up with a emaciated or thin body stature because they are started on dal ka pani and all those raw vegetables. So I would always say that our lipid profile is primarily affected by our genes. Our genes are going to decide, these are endogenous factors which are going to decide our cholesterol. So 85% of our total cholesterol is endogenous, decided by our genetics. Only 15% is the one which is going to affected by our diet. So I won't say that you should be very, very strict on the diet thing, because this is something I would say modifiable thing. So we can't say patient to eat anything. Of course, 15% is the one which is modifiable thing. So we should tell them not to eat anything haphazard. But I would say that a routine diet and a good dose of statin, which can take care of LDL and HDL both.
Thank you so much, sir.
Dr. Goel, I think he wanted to say something. Sir, you wanted to comment something on this?
No. I think this is very well said, because obviously there can't be one single kind of diet post CABG. But as a general statement, what you said was so valid. I know so many people who are almost emaciated after a stent because they are so scared of things that they believe that if they have even a chapati, normal chapati, they will have another heart attack. So I think that's so well said. It gives the message loud and clear. Thank you.
Actually, sir, we get an excuse. I mean, once in some odd day, if we have some stent restenosis, then we took a full complete history of the patient, that on which day you had some ghee lagi chapati. So we are just looking for an excuse that why your stent was blocked, because you had that ghee lagi with chapati that day. So we look for an excuse.
Yeah.
All right, sir. Thank you so much, Dr.
I have a few questions for Dr.
Sure, definitely, sir.
Ravi.
Yes,
Because people have been sending me questions. So,
yes,
Dr. Ravi, one thing is about lipoproteins and homocysteine levels.
Yes, sir.
Coronary disease. How does one interpret them?
Sir, actually, I would say that lipoprotein, LP little a actually, and homocysteine, around 10, 15 years back when these things came in, they got a lot of limelight and people start correlating. We have sufficient data to say that they are a very good correlation with the LP little a and homocysteine values. But I take it in a way that we become wiser as we learn some new thing, and history repeat itself. So I mean, whenever we get a new risk factor, we start thinking that this is the only thing, and over the time we learn that this was not the only thing. Probably new things are coming in, so this probably has a better correlation. I mean, as a student, we were told that diabetes, blood pressure, smoking, these are the conventional risk factors. But over the time, we learned that almost 50% of our patients, they have no conventional risk factors. So, I mean, there are something beyond this. LP, little a, and homocysteine also came in picture, took a lot of spotlight. And I think, I mean, we are still using them, but can't totally rely on that.
Okay, and one more question about any long-term side effects of statins.
Sir, actually, there are only one or two side effects of a statin. One is the effect on the liver, which leads to increase in the SGOT and SGPT. And this is the major effect which we look for. And most of the patient, we need to check their SGOT and SGPT, ideally baseline before starting the statin, and after 3 months of statin therapy. And if the OTPT are rising more than 1.5 to 2 times above the normal limit, then we should consider that transaminitis or the OTPT rise. Then only these statins should be stopped. Otherwise, I think we can continue statins. The dose would be decided on every 3 months lipid profile. And most of these people, after the procedure, we send them on a high dose, 80 milligram of atorvastatin or 40 milligram of rosuvastatin, because this index event, whatever their lipid profile was bad. So we consider that irrespective of their LDL value or HDL value, on the index event day, it was bad for them. So we give them maximum benefit of this thing. After 3 months, we will check their lipid profile, and then we will adjust our dose of statin.
I think that's wonderful. So I think before Dr. Darshika signs you off, let me say, Dr. Gupta and I worked together in Wockhardt Hospital, and he's one of the most versatile, not only cardiologist, versatile doctor I have come across in my life. Besides being an excellent interventionist cardiologist, he has books published on cartoons. He's almost a professional singer and a multi-talented personality. Unbelievable that somebody can achieve so much in his life. So thank you, Dr. Gupta, for sparing time to join us today.
Thank you very much, sir.
If you can stay back for another 15-20 minutes, we can wind up and maybe take a few more questions.
Thank you, sir.
Dr. Darshika.
Lovely, sir. I think it is lovely to have Dr. Gupta here. So I would now like to invite Dr. Goel for sharing his expertise on the same. So.
All right. So I think much has been said by Dr. Gupta about the impact of obesity on heart. So I'm not going to cover that. I'll be talking primarily on the impact of bariatric surgery on cardiovascular disease. And now there is enough published data. So when we started this surgery about 21 years back, there was a dearth of data on this, and there were more hypothetical things. So I'll be doing more of a evidence-based presentation, because it's very difficult to establish this role in one's practice unless you have a very large patient pool followed for a very long term to see its impact. So I'll share my screen and try to show you some of this data today. Dr. Darshika, are you able to see this?
Yes, sir.
Yes, sir.
All right. So greetings from Center for Metabolic Surgery in Mumbai. And so we talk about impact of bariatric surgery on cardiovascular diseases. And there are evidence that the weight loss is not only recommended when you are 30 BMI or 30, 40 kg more, even at 25 BMI. And if somebody has cardiovascular risk factors or other comorbidities or increased waist circumference, one should be looking at weight loss. So each of these are independent factors for weight loss. So, whether BMI is more or not, but if there are cardiovascular risk factors, waist circumference is more, one should be looking at weight loss. Now, as far as obesity management is concerned, these are the Indian guidelines which were published, and which says that if patient can maintain weight with diet and lifestyle intervention, very good. But if the person can't maintain, and if person has uncontrolled diabetes, then bariatric or metabolic surgery can be offered even at 27.5 BMI, which is as good as just excess weight of 8 to 10 kgs. It's not morbidly obese people. These are just 8 to 10 kg overweight person with uncontrolled diabetes. If somebody has a comorbidity, let's say a sleep apnea or any other comorbidity, then one can do it at around 32.5 BMI. And if somebody's BMI is 37.5, and even if there is no comorbidity, one can offer this surgery. So the reason why these BMIs have been lowered is primarily to offer this surgery for disease control over the weight loss. So now we are targeting that we should be able to help in treatment of various diseases and maybe prevent those diseases in happening early rather than when they become morbidly obese. Now there are various types of diets, you hear about them, but I'll talk about the evidence around these diets. So there are low-fat diets, there are medium-fat diets, and there are high-fat diets. So this is 20%, 30%, and 40%, and accordingly the carbohydrates change. So in the non-diabetics, one can achieve better weight loss in low-fat diet in 6 months. Okay, but in diabetics, this doesn't work. In diabetics, a low-carb diet. So low-carb is a high-fat diet. So low-carb diet works better, and it gives a better weight loss. While in pre-diabetic, better quality carbs are required to get a better outcome. So in diabetic and pre-diabetic, carbohydrate restriction or quality of carbohydrates are more important, while in non-diabetic, fat restriction is important. And this is published. I'm not going into keto diet and intermittent fasting kind of discussion. The second question that comes to our mind is, does these lifestyle changes work? So the purpose always of this of weight loss is to reduce risk factors of heart diseases like hypertension, dyslipidemia, and diabetes, to reduce heart diseases and fractures. Okay. Now the outcomes are that meaningful weight loss in immediate period, but unable to sustain for more than 1 year. So all these lifestyle changes, all these popular diets can work, but it's difficult to sustain over 1 year. And there is enough published data to say that most of these diets or medicines are not associated with long-term successful weight loss. So comes a bariatric surgeon or a bariatric surgery for patients who qualify for these procedures. These are the commonly done procedures. Everybody knows about it: sleeve gastrectomy, Roux-en-Y gastric bypass, or a mini gastric bypass, or endoscopic procedures. I'm not going to procedures today because we are talking of the cardiovascular issues. This is our published data where it shows that at 1 year with sleeve, average weight loss was 87% and 97% excess weight loss at 1 year with bypass. And even after 3 years, these patients are still maintaining 72% weight loss or 86% weight loss. So which is quite good. And to show you, this is the same study which shows that hypertension control with sleeve, almost 55% patients go off medicines for hypertension at 3 years, and 80% of them are off medicine for hypertension at 3 years after bypass. Rest of them, what happens to other patients, other 45% patients, they are reduced medicines in another 13% patients after sleeve and 10% patients in bypass. But still there is a 31% patients who may still continue to require the same amount of medicines for hypertension, and 10% after bypass for hypertension even after bariatric surgery. So that gives you a perspective that bariatric surgery helps a large majority of patients in terms of hypertension control even in long term of 3 years. Now what about cardiovascular disease? Obviously, there is early and sustained weight loss. Remission of cardiovascular disease risk factors: 73% of diabetes is remission, 63% of hypertension, and 65% of hyperlipidemia gets corrected. And there is decreased mortality by 40%, reducing mortality. And this reduction of mortality happens because there is a 56% reduction of mortality in heart diseases, 92% of mortality reduction because of diabetes, and 60% of mortality reduction because of cancer-related deaths. And these are all published. The second reference about mortality was published in New England Journal of Medicine in 2007, and the first one was in Circulation in 2013. Now, Just to show you this lady who had severe diabetes, snoring, hypertension, and had significantly changed her not only appearance but her health status. Now, it's not about this, even the heart function improves. So heart failure is seen in about 5.5 million patients. It's supposedly called a global pandemic. And 40% of them are obese. Now, primary prevention, people who don't have heart failure, if a bariatric surgery is given to them, the risk of heart failure is reduced by 5 times. And this is a very large study of 47,000 patients. And this was published in Journal of Cardiac Failure. Secondary prevention is when there is a patients who already had heart failure, and they have found that there is a 40% reduction in their heart failure episodes. So it's not only a question of that it prevents heart failure, but even those patients who have poor ejection fraction, if surgery is offered, it reduces their heart failure episodes. Now, post-bariatric heart function improvement, this patient we had operated at Wockhardt only a few years back. This gentleman was 45 years, came from UAE, had heart replacement in 2014, where his ejection fraction improved from 25% to 35%, was referred by a cardiologist from Wockhardt Hospital for bariatric surgery. And in December 2015, we operated him almost 1 year after his heart replacement. And at that time, his weight was 190 kg. We did a sleeve gastrectomy. And within a year, his ejection fraction improved to 45%. It has gone to about 58% when I last saw him about 2 years back. So it dramatically improves heart function in patients where surgery is feasible. So the main criteria is whether patient can tolerate surgery, can tolerate anesthesia. Then comes a more common problem like angina. Now, the angina, as per the data shows, it's about in 8 million people in USA with 22,000 hospital admissions. Now, if we offer bariatric surgery in patients who are morbidly obese or who are qualified for surgery, only 0.4% will have angina after bariatric surgery compared to 1.8% in non-surgical group. So a significant difference in primary angina in these patients. And those who already had angina before they were offered bariatric surgery, the hospitalizations reduced by 2/3 after bariatric surgery related to angina. So this is the kind of evidence that you can see and know that angina is reduced. Now, as far as hypertension is concerned, if a surgery is offered to a person who is normotensive, then it is seen that there is a 50% reduction in new onset hypertension after bariatric surgery. But if you offer it to patients who already are hypertensive, then there is an improvement, reduction of 30% antihypertensive medication. And in 84% after the bariatric surgery compared to 13% non-surgical group. So there is a reduction of antihypertensive medication. And this is almost the same data that I have shown you, that there is a remission in 51% patients in bariatric surgery group versus no patient in non-surgical group. So patients who are hypertensive will continue to take antihypertensive medicines because obviously it is required. But after bariatric surgery, 50% of them will be able to stop the medicine for hypertension. Now, what about the conduction defect, dysarrhythmias or atrial fibrillation? So those who never had that after bariatric surgery, 29% will not have first-time episodes after bariatric surgery over a period of 19 years. And this has been seen especially if this is offered to young people and those with higher diastolic pressure. So this is an important determinant of offering bariatric surgery to those people who are having higher diastolic pressure early and those who are in young age. While those who already had dysarrhythmia, there was no significant reduction in atrial fibrillation episodes in long run. But it has been reported that there's a 50% reduction in AF-related mortality. So friends, this is the kind of research being done with cardiologists and physicians all over the world in collaboration with bariatric surgery surgeons and bariatric programs. Now, as far as the thromboembolism risk is concerned, it has been seen that there is no significant improvement in thromboembolic risk even 2 years after surgery. So even though they lose weight, they must be treated as a high-risk patient, the way Dr. Gupta was talking about statins in patients who are high risk once they had a coronary artery disease. So if somebody is morbidly obese and is a high-risk person for venous thromboembolism, they should be treated adequately and adequate precautions should be taken in long run. This lady who came from South Africa had obstructive sleep apnea, high blood pressure, and lost almost 33 kg weight and was off medication for blood pressure. So to conclude, take-home message, bariatric surgery remains the only sustainable weight loss tool in patients who qualify for this. It helps in improvement of hypertension, diabetes, cholesterol, heart function, etc. Overall, reducing the risk of heart diseases. So this is what we have together. We wanted to communicate to the family physicians who are attending it on DocPlexus platform, and I'll be very happy to take questions.
Thank you so much, Dr. Raman. We do have some questions for you, sir. So my first question is, bariatric surgery surely has benefits effects on a number of risk factors for CVD. However, outcome of patients who currently have both CVD and severe obesity undergoing either bariatric surgery seems to be debatable. So what are your views on that?
I think there is no debate about it. Cardiac, if a patient of somebody asked me this question, I said, if there is a cardiac problem, patient is not coming to us, patient is going to a cardiologist. Because obviously, patient with coronary artery disease, heart is the most important thing that gets precedence over everything else. We face bigger challenges in respiratory problems, in renal problems, but in coronary problems, we have no challenge because if they have a diagnosed coronary artery disease, they must get it treated first. Only thing is we talk to the cardiologist and say that we might be operating them 6 months down the line. So you decide about what kind of stent you want to put in because we will have to stop the clopidogrel and shift him to, or her to something else. But that's the only thing. Coronary artery disease is a very simple thing to manage. Send them to Dr. Gupta and he will take care of it.
Sure, sir.
Dr. Gupta, do you want to add something to this debate? I don't think there's a debate in it.
Sir, no issues on this thing. I mean, of course, the patient has to be live, whether he remains fat or lean.
Absolutely, absolutely. True.
I remember, sir, one of our patient, I don't know whether you recollect this or not, one of our patient was posted for a bariatric surgery. I don't know whether he was a bariatric surgery or something, but he was very obese and he was not able to do any functional assessment of coronary artery disease. Echo was normal. His ECG was also normal. He had no cardiac symptom. But just by hunch, I sent him for a dopamine stress echo, and he developed MI in that dopamine stress echo. Then he was rushed to cath lab. We did a complex angioplasty.
I remember that patient. You
remember that patient?
And I asked you this question. Why did you ask for it? Because you don't normally ask from all of our patients. I said, what was the reason? Why did you suspect? And you said the same thing. You had a hunch that there is something is not right.
And that actually turned out good for the patient.
Yep, absolutely. Thank you.
Sir, I have one question.
Yes.
And actually, I'm just a comment or a query. I mean, you showed a data that deep vein thrombosis events are less. I mean, they are not improved by bariatric surgery. Actually, logic says, I mean, if you talk about the common sense, then I believe that the incidence of deep vein thrombosis should decrease after bariatric surgery, because most of the people, they are bedridden. If they are not moving their legs, they are more prone to develop deep vein thrombosis.
Yeah.
When after surgery they start mobile, the chances should decrease. I don't know why this data you shown one slide in which after 2 years there is no decrease in the deep vein thrombosis. So I'm not able to understand.
So the answer to that is logic and science don't go together. Science is statistics and logic is common sense. So, when I showed you this data, because I always used to tell patients that this possibility will reduce, you will be more mobile and all that. But when I looked up for this presentation, the published data, I found that this is not happening. And really speaking, except where one patient who had recently had a thromboembolism in post-operative period, most of the thromboembolic episodes happen in our patients 2 to 3 years down the line, even though they have lost 70, 80 kg weight. So I think this has a somewhere it echoes in my mind repeatedly, and I did not wanted to show that only bariatric surgery is serve all and treat all kind of thing. But we can probably do this. We can probably analyze our own patients' data set, and we consult next to each other on the same floor.
Yes,
I'll share this data with you, and we can talk about it.
Yes. Thank you, sir.
Since Dr. Gupta already asked the question, I think my next question is also similar, which did ask about could bariatric surgery help to reduce the risk of venous thromboembolism, as obesity is one of the strongest risk factors for developing that.
So I think I believe there is what Dr. Gupta was saying and what we have learned during COVID. Endothelial dysfunction is also a major determinant. So after weight loss or after reduction of LDLs or whatever, is the endothelial dysfunction reversed? We need to see that, and we can. When I was saying that we will dig out our data, we need to see whether those patients who got DVT episodes 2 to 3 years down the line, what were their LDL levels and all, and we see whether that was determinant of this. So I think, Dr. Darshika, this is something we need to really, it's a very thoughtful idea, and we will definitely look into it very carefully soon.
Sure, sir. I think this brings us to the last segment of our talk here. So we have a patient with us, Dr. Asif. So if you could just switch on your camera.
Ma'am, I think you have disabled me.
Okay. How is that possible? Dr. Asif Pochi is a family physician practicing in Mumbai.
Good evening, all.
Good evening, Dr. Asif. Yeah, Dr. Darshika, please go ahead.
So, sir, I would like to know about your feedback or your journey of weight loss. So what were your problems, that physical or psychosocial, which made you decide to sort of go for the surgery?
Basically, my weight was 114 and I approached Goel, sir. Previously, when I had approached Goel, sir, I had visited 3 more surgeons for this bariatric surgery. So, because of my weight, I am unable to walk along, and that's the only reason. And recently, I addicted with diabetes mellitus and hypertension. Post-COVID, I had started these symptoms. Since 1 year, I was on hypertensive medicines, and recently I started anti-diabetic medicine. So that my biggest fear was this: diabetes ho gaya, abhi hypertension tha, diabetes bhi ho gaya. So I'm wondering about that only. So I visited Goel, sir, at the last, and that was my final decision. Sir पूछा कि क्या करेंगे, कब करेंगे? मैं बोला सर जितना जल्दी हो सकता है. So was worried about that only. I'm having a big belly. Rest of all my body parts are in a proportion way, but the big belly is creating the problems. So I was having sleep apnea and all that. Just recently diabetes, hypertension, sleep apnea. So that create havoc with me. So after visiting Goel, sir, I understood lots of these positive vibes from sir. So was very happy after reducing 20 kgs of my weight in the last 2.5 months. Still the weight is reducing. So I was quite happy क्योंकि पहले का experience और अभी का experience. So अभी long भी अगर मैं चल लेता हूँ तो I'm having no problems with mask. क्योंकि अभी आजकल कोविड चल रहा है तो mask is compulsory for anywhere. So after a long walk, I don't need up anything. So it's going very well now. So I'm feeling quite energetic now. पहले ऑपरेशन के बाद थोड़ा सा डल फील हो रहा था quite for 1 month. So after 1 month, I'm feeling that energy level is again. I had started everything. Energy level is also high. My speed is increased, and belly is gone down.
That's great, sir.
So at
That's
around
great to know.
my waist side, I think 3 inches are laced within these 2 months.
That's great. Sir, I would also want to know about the lifestyle changes that you had to, take care after the surgery and what encouraged you to stick to them.
मेन फैक्टर इज लाइफस्टाइल चेंजेस मैम, क्योंकि जब तक हम लाइफस्टाइल हमारी चेंज नहीं करेंगे तब तक कुछ नहीं होने वाला है. आफ्टर सर्जरी इट्स रिकमेंडेड so that protein shakes. I had not taken a protein shake in my life, so I'm taking the protein shakes. Now I'm taking the less amount of food. Previously जब खाने को बैठते थे तो we don't having a limit. Now we are having some limits, so that brings some this changes very drastically.
Sir, I would also want to know about if you could talk about the insurance coverage for your surgery.
Thanks to Raman Goel sir, he had done everything. क्योंकि सर ने मुझे बोला ही थे पहले कि मैं मैक्स पूरा कोशिश करूंगा कि आपका मैं सर्जरी मेडिक्लेम में कवर्ड करके टाइप इंश्योरेंस हो जाएगा जो भी है वो. So I'm having a very good experience in Wockhardt Hospital with Raman Goel sir, and because sir might be remembering this, I was the only person who had attended this surgery. Nobody from my side is there in the hospital, so I was alone from the admission to discharge. And I will appreciate one thing from Wockhardt Hospital, that the nursing staff was very efficient. Because after the surgery, sir का ये था कि within every 2 minutes they are having one sip of water. So that lady is coming for every 2 minutes, and she's putting one sip in my mouth, and again she's going one sip, going one sip, going. Means hats off to that guy. हर 2 मिनट में आकर वो मुझे वन सिप देके जाती थी, हर 2 मिनट में, एंड शी ऑलवेज इज देयर. वो मैं अकेला होने के वजह से दे आर एक्स्ट्रा कॉन्शियस, और रमन सर का शायद आई थिंक इंस्ट्रक्शंस होगा उनको, दे आर टेकिंग केयर. तो आई वाज वेरी हैप्पी दैट टाइम.
Thank you so much, Dr. Asif, for your feedback, sir. So at the end of the session, Dr. Raman, if you have any closing remarks for us here today for the session.
So I think Dr. Asif had surgery recently, about 2.5 months back.
Correct.
And I remember when we started these bariatric surgeries, there was a big resistance from the medical community because nobody thought that this surgery is actually scientific. I'm talking 20 years back. And now the situation is that on an average, on a monthly basis, we operate on 2 to 3 medical doctors, whether they are postgraduates or family physicians or specialists. So more and more of them are getting convinced that this is working. And Dr. Asif, as he was mentioning, he came and he said, I want surgery to be done. And I was so insistent, please at least bring your wife along or family member along. And the only thing that he brought one of his friends for the surgery. But he has been very compliant. I was not very sure whether he will follow instructions, but he has been following and a great patient in long run. So I think besides the patient issue, the heart diseases is one of the major determinant of our longevity. And reduction of risk factors to heart diseases and avoiding them in like primary prevention is so important. And that's why we should be looking at long-term weight loss. The problem is everybody is looking for a short-term gain. For 3 months, 6 months, we saw some ad about a pill to swallow and all those things. They are all 3 to 6 month thing. It's like going on a diet for 3 months and then you go off it, or you join a gym for 6 months and then you stop. Ultimately, we need to look at whether I will maintain my weight 10 years down the line. And that is what cardiologists or physicians are looking for, because the risk factors get reduced if you maintain your weight long term, if your sugars are euglycemic for a long term. So I think I can only thank Dr. Ravi for joining today and sharing this wisdom. I learned a lot from you, and I'll come and discuss about, because so many of our patients have low HDL, and how do we improve their HDL before surgery. So thank you so much, and thanks to Doc Plexus for hosting this program. Dr. Darshika.
Thank you so much, sir. This brings us to the end of the session. And on behalf of Doc Plexus, I would like to thank Dr. Ravi Gupta for taking us through this useful session to understand the vital relationship between obesity and heart diseases and the importance of sustainable weight loss, as Dr. Raman Goel mentioned. We are highly grateful for your participation, sir. A big shout out to Dr. Raman Goel as well, and the Center for Metabolic Surgery for bringing relevant topic discussions around obesity management every week for our community of doctors. And very grateful to our dear viewers for their undivided attention and kind listening. So stay tuned for our next Thursday CMS session. And until then, please take care and have a great evening ahead.
And Dr. Asif Kochi, because patients, it's not easy for a patient to come on a public platform and share their experience. So thank you so much, Dr. Pochi, for joining in. Thank you. I appreciate that.
Thank you
so much.
Thank you.